All right, so for the spinal cord, this is the spinal cord. It begins at the foramen magnum. If you remember your posterior cranial fossa, it begins at the foramen magnum as a continuation of the medulla, right? And it ends opposite intervertebral disc, that is between L1 and L2 vertebra. Right? So structure-wise, the spinal cord has white matter, then gray matter. So what differentiates it from the brain is that the gray matter for the spinal cord is at the center. So gray matter for spinal cord is at the center, which is this butterfly-shaped structure here. That's your gray matter. It's at the center. Then the white matter for the spinal cord is at the periphery, right? So unlike the brain where the gray matter is on the outside, then the white matter is on the inside. For spinal cord, gray matter is at the center, then your white matter is on the peripheries, right? And this spinal cord, just like the brain, it's going to have coverings on the outside. And those coverings are what we call the meninges. Right, so maybe I'll use this picture here. So the meninges are the coverings of the spinal cord on the outside. And there are 3 in number. So on the outside, there is dura mater. You just remember that outside your house, there's a dura wall. So we have dura mater on the outside. Then going inward, there is arachnoid mater. Then we have pia mater. Yesterday, when I was talking about lumbar vertebra, I went on to say, lumbar and sacral vertebra. I went on to say that even though the spinal cord ends at intervertebral disc L1, L2, the meninges do not end there. So the meninges, which is dura and arachnoid, they end at S2. They end opposite sacral vertebra number 2. Right. Then pia mater, which is closely attached to the spinal cord, it ends where the spinal cord ends. Right, so where your spinal cord ends, that's where pia mater ends. And it continues as a purplish structure known as the phylum terminal. Right, if you look at this here, at the center there's this sort of like purplish strand that is going all the way down to attach to the coccyx. That's what we call the phylum terminal. So pia mater ends where the spinal cord ends, right? So between the dura mater, which is this, between the dura mater and the vertebral bone, there is a space there. So between dura mater and your vertebral bone, there is a space here, an empty space, which we call the epidural space or extradural space. This is not the case when you go to the brain. That space is not there. Right? So there is this epidural space. What is found in that epidural space? There is fat. There is a vertebral venous plexus. Right? Then your arachnoid mater, it's translucent, right? And your pia mater is closely attached to the spinal cord, like I said, right? And pia mater ends opposite intervertebral disc L1, L2, where the spinal cord ends. Unlike dura and arachnoid, which we said they continue all the way down to S2 vertebra, right? Then still on this, in terms of blood supply to the spinal cord in general, The spinal cord, on its anterior surface, it gets blood from one anterior spinal artery. However, on the posterior aspect, there are two posterior spinal arteries. Right. So there's one anterior spinal, but we have two posterior spinal arteries. Where these arteries are coming from, even if I mention it now, you may forget if you haven't done your sec of Willis. Right. But basically, the anterior spinal arteries, they come off. It's one, remember. So there are two branches that come off the left and the right vertebral arteries, respectively. Then they connect and form an anterior spinal artery. The same vertebral arteries can also give me posterior spinal arteries, right? But in other cases, your posterior spinal artery will be a branch of an artery called posterior inferior cerebellar artery. So PICA, PICA, posterior inferior cerebellar artery. PICA is also a branch of the vertebral artery. So vertebral artery can give off posterior spinal artery directly, or it gives off PICA, which then gives us posterior spinal artery, right? So it would be okay to just know for now that there is an anterior spinal, then there are two posterior spinals, right? But these arteries are very small. The spinal cord gets all the way down to the lumbar region. So they are reinforced by arteries. For example, these two sets, the anterior and the posterior, they carry blood for the cervical spinal cord. But they continue all the way down to the thoracic spinal cord, the lumbar spinal cord. But in all those regions, they will now be fed by other arteries. For example, when we do thorax, we are going to see intercostal arteries in your intercostal spaces between the ribs. So those intercostal arteries, they are called reinforcing or radicular arteries that feed blood to these arteries. When you get to the lumbar region, there will be lumbar arteries that also send blood to the spinal arteries. And the greatest or the largest of these radicular arteries is known as the great artery of Adam Quits. The spelling may be running away from me, but I'm sure if you Google about the great radicular artery, it will give you in brackets great artery of Adam Quits. Right? It's usually a branch of the aorta. So just know that we have an anterior spinal, then we have a posterior spinal. These arteries are not large enough to carry blood for the entire spinal cord. So they are reinforced by other arteries, for example, the intercostal and the lumbar arteries. Right. Then in terms of venous drainage, we have what we call vertebral venous plexuses. So there's an internal vertebral venous plexus, then there's an external vertebral venous plexus. When you do pelvis, you're going to do an organ called the prostate. And prostate, by now, I think everyone knows that prostate is one of the most commonly affected sites by cancer, right? So cancer of the prostate has a propensity to spread to the vertebral column because the veins of the prostate communicate with the vertebral veins. I have an uncle who has prostate cancer, and recently we went to see him, and he was saying that I think for the past 2 months he's been experiencing some back pain. It's then hard to tell people that the cancer is spread, but that's the reality of it. When this cancer spread, back pain is one of the typical features because there is no valve that limits flow of blood from your prostate to the vertebral plexuses. So cancers can spread via the lymphatic system. They can spread hematogenously via the blood, or they can spread via seeding. For example, in your peritoneal cavity, pleural cavities, whatever. That's another way of spreading cancer. So these plexuses are quite important in your prostate cancer, right? Then they also talk about longitudinal veins. Is that a question? Please do stop me when you have a question. There are also longitudinal veins around the vertebra, these ones. And they're about 6 in number, 1 anterior, you have 4 on the sides. That's 2 this side, 2 the other side, then another one on the back. Right? But all those veins, they feed ultimately into your vertebral venous plexus. Right? Then when you eventually do neuroanatomy, they'll tell you that these arteries, the spinal arteries, they have regions where they are narrowed. Right? So anterior spinal artery is a region where it's narrowed. Posterior spinal artery is a region where it's narrowed as well. So when you get ischemia or reduction in blood flow, those regions will be the first to be affected. Right? Then coming back to this general structure for the spinal cord, remember I said gray matter at the center, this butterfly-shaped region, then white matter is on the outside. So this gray matter, it has what we call an anterior horn, then a posterior horn. Then in other regions, there is an intermedial lateral horn here. This is where spinal cord gives you sympathetic. So I'm sure you guys have done physiology of nerve and muscle, where you talk about the parasympathetic and the sympathetic nervous system. And sympathetic outflow, it's thoracolumbar. So thoracic and L1, L2 segments of the spinal cord will also have this additional lateral horn here. Right. So there's a law. It's called the Bell-Majendi law, or Majendi, whichever way you pronounce it, which states that motor is anterior, sensory is posterior. So the anterior horns are for motor. The posterior horns are for sensory. You want to make common sense of it. The periphery, if I touch my forehead here, that's sensory. So this is, I'm going to have a nerve that lives here and it goes all the way back. And maybe the head is a wrong example since it's not linked to the spinal cord, but let's use the finger. I'm going to have a sensation. It enters the spinal cord via the dorsal horns or the posterior horns. Then from the anterior horns, I have a nerve that exits. This is now motor. To say if I've bent this finger, I need to move away the finger. Right? That's the explanation I'm going to use when we talk about the reflexes. But to understand those reflexes, you need to know that there is motor and there is sensory in relation to the spinal cord. Like that's the simplest thing we can talk about before we include the Golgi tendons and whatsoever. Let's just say there is motor, then there is sensory. Motor leaves the spinal cord via the anterior horns. Sensory enters the spinal cord via the posterior horns. Right? So what happens? The anterior rootlets, these ones that are exiting the spinal cord with motor, they join the posterior rootlets, these ones that are entering the spinal cord with sensory, and they create something called a spinal nerve. Right. So a spinal nerve is only 1 centimeter in length. Right. So I'll take you back to something that I never described when we were doing the vertebra. Okay. Can I find a picture? Okay. Oh, okay. So this is a vertebra. Can you see where? I remember I said pulp yesterday. The pedicles are anterior, the lamina are posterior. So can you see the pedicles where they are attached? They don't attach on the entire body. They leave a notch below here and another notch on top there. Right. And notice the notch below, which is called the inferior vertebral notch, it's larger than the notch above, which is your superior vertebral notch. So now imagine there's going to be another vertebra here. It's also going to have something like this. We're going to have another notch and another notch there. So inferior vertebral notch for vertebra above and superior vertebral notch for vertebra below, they create a foramen, right? And that foramen is called intervertebral foramen. It is between two vertebrae, hence the name intervertebral. And within that there's this picture that I just saw. Within that intervertebral foramen, that's where the spinal nerve is. So that 1 centimeter of a spinal nerve is within that intervertebral foramen. What forms a spinal nerve? Anterior roots and posterior roots. The posterior roots being sensory, the anterior roots being motor. Immediately after being formed, that 1 centimeter of a spinal nerve will then divide like this. Yeah. It will divide into an anterior ramus and a posterior ramus. A ramus is a trunk. So anterior rami, not knowing if you guys have done embryology of somites, epimeres, hypomeres. Have you guys done that before?
No.
You haven't. Okay, so I will try to describe this in layman terms then. Anterior rami, they innervate ventral body wall muscles, meaning muscles on the front, as well as muscles of the upper limb and muscles of the lower limb. And the skin for those regions as well. Posterior ramus, which is the smaller one, it innervates muscles of the back. That's in layman. But when I say muscles of the back, I'm referring to the deep muscles of the back. Probably the lesson we are going to have next after we finish spinal cord when we do the muscles of the back. The deeper muscles of the back are the ones that I'm referring to. The superficial and the intermediate, they are not innervated by this posterior ramus. Right? Skin of the back, it's posterior ramus as well. Such that when you guys now do upper limb and you talk of a brachial plexus, in as much as people say C5, C6, C7, C8, T1, that plexus, the statement for it to sound correct, it should read, it is formed by anterior rami of C5 to T1. Because posterior rami are not involved. They have nothing to do with the muscles of the limbs. So a spinal nerve, that's your spinal nerve, 1 centimeter in length. It's mixed. It has both motor and sensory. Then immediately after being formed, it divides into an anterior ramus and a posterior ramus. Right. And then the posterior rootlets, maybe this you know when you're doing neuro, but the posterior rootlets, before they enter the spinal cord, they synapse in this that we call the dorsal root ganglion. This structure here, the spinal ganglion. In layman terms, a ganglion is just a collection of cell bodies outside the central nervous system, versus what we call a nucleus, which is a collection of cell bodies inside the central nervous system, which is inside the spinal cord, the brainstem, and the likes. Right? So that's a spinal nerve. And spinal nerves, they depend, what they innervate depends on region. Right? For example, C1 to C4, you talk about the neck, C5, whatever. This you will come to do when we do region. So there's no need to claim this. Right? But there's something that I want to bring your attention to. There's something called a dermatome. Right? Does anyone know what a dermatome is? Great. This is a very good picture of dermatomes. Does anyone know what a dermatome is? There's no wrong answer here, guys. We are all learning.
I think it is the area of the skin, like on your body, that relies specifically on nerves from your spine.
There's nothing wrong with your statement, but you need to quantify. So it's an area of skin supplied by a particular spinal nerve. For example, I can map out T2 dermatome here, going all the way into the axilla. That's skin innervated by T2 spinal nerve. Also extends to the back there. Right? So dermatomes are just areas of skin supplied by a particular spinal nerve. What about a myotome? What's a myotome? Myo means what, guys? Demis, skin.
Oh.
Myo means?
Oh, okay, and not myo, but I was thinking, good see, myotome is like a group of muscles which are innervated by a single spinal nerve root.
So it's not usually a group of muscles, but a group of muscle fibers. Because you'd find, for example, biceps will have myotome C5, C6, C7. Right? So these are now, if I say C5 myotome, these are the specific fibers in all the muscles that are innervated by C5 or maybe C6 or L1 or whatever. It's not necessarily the whole muscle, because rarely will you find a muscle with one myotome. Right? So it's a group of fibers that are innervated by one spinal nerve. Why is it important to know dermatomes? I think when I was going through your outline, it said describe dermatomes and their significance. Why do you think it's important to know that this is C4 dermatome, this is T2, this is L2 dermatome? I love neuro so much, so it's something I'm quite passionate about. So as why do you think it's important for us to know dermatomes? If someone was to ever have a spinal cord injury, what's the quickest way for us to know where the injury is?
I think it helps to know like which region is supplied by which nerve and which nerve is damaged.
Right?
I
So
think so.
so what you can simply do. Spinal cord, remember it's cervical, thoracic, lumbar, sacral, coccygeal. So for you not to introduce bias, let me draw here. If this is cervical spinal cord, thoracic, lumbar, sacral, if lumbar is not working, if the problem is in the lumbar spinal cord, if you start touching this person, say in their cervical regions there, they can feel because it's working. Thoracic, they can feel, but it's hard for them to tell you when they can no longer feel because they started by feeling. So you start your neurological examination lower down at the foot there, where the sacral, where there is sacral innervation. So you put your cotton wool. They're closing their eyes. Ask them, do you feel anything? They don't. You go up, you go up, you go up, you go up until they tell you that they can feel something. Maybe they'll feel something in this region innervated by L2. So you know that the spinal cord beyond L2, it has been affected. Right. That's why it's important to map out this. Another importance, there's what we call referred pain. Referred pain, it's quite important when we do abdomen. I'm sure most of us here have had a stomach ache or something. Has anyone had their appendix removed here? I'm sure 1/3 of the world's population gets their appendix removed, something like that. Has anyone had an appendix removed here? Or a problem with the appendix? Okay, maybe no one. Can anyone feel their stomach right now? Hello? Can you guys feel your stomach? You can't, right? But you know it's there, right?
No, you can't.
But you know it's there. So,
Yeah.
so there's a way to tell when there's a problem with the stomach or maybe any organ, because your brain cannot perceive it as it's unconscious proprioception. There is no conscious proprioception from there. So I'll use appendix as an example because it's the most common thing. It's most common thing. Appendix gets its innervation from sympathetic nerves T10, right? But can you see T10 is a dermatome on the body there? Can you see it? So when you get a problem with the appendix, it will refer the pain to a somatic structure which the brain can perceive, which is skin. So what takes you to the hospital is pain that is referred to the skin, but the problem is inside. The only time you get to feel your appendix or your stomach is when it ruptures. That's when the pain becomes what can I say? When it tears or stretches, that's when the pain then becomes noticeable from that region where the appendix is. I'll draw for you where the appendix is. Appendix is somewhere here, where I've shaded there. But the pain goes at the umbilicus there. The reason why abdominal pain refers to the midline, all of it, is because embryologically, the whole gut tube starts in the midline before the organs swell and whatever and rotate. So all the organs refer the pain to the midline initially. So referred pain helps you to understand, because you know that if pain is in the region of dermatome T10, more likely it's mid-gut organs. Over time, you know what the mid-gut is. Starts halfway down the duodenum to somewhere on the transverse colon, junction of proximal 2/3 and distal third. If you know that the pain is T7, T8 there, that's foregut, which includes the stomach. For the heart is innervated by T1 to T4. And this is the region where the heart pain will go. Think about people with angina. Even people tell you about pain going to the left arm or right arm because T2 goes there. Right. So these are applicable things. They are not just, mapping the body for just mapping it. Right. So it helps us with the referred pain, which as a doctor, I think that's all you know. No one comes to you and tells you that my stomach is a problem. They don't know that. They're lying to you. And no one comes to you and tells you that I have a stomach problem and you actually get to open their stomach. You don't do that. Right? You are working with this. That's why this becomes the basis of your pain management or pain practice, whatever, as a doctor. Right? Then the last thing is a reflex arc. So I'll go back to that picture. A reflex arc, a simple reflex arc should have a sensory and a motor nerve. I know other people prefer to use the words afferent and efferent, but those words can confuse you if you don't use the word sensory and motor first. Right. So from the periphery, say your hand has gotten into a fire. From the periphery, there's a sensory nerve that comes. Right. Then that sensory nerve synapses in the spinal cord. I probably won't get a good picture, so I'll just resort to drawing. So that sensory nerve comes. Here is the spinal cord. It enters the spinal cord via the dorsal root. Then there's a cell body there of a motor nerve that should exit. So what happens is the sensation of the heat comes via the sensory nerve, which is your afferent nerve. Then the efferent nerve, the motor nerve, which goes to muscles, it exits immediately to go and effect on the muscles so as you move your hand away from the heat. So this monosynaptic reflex, it's mostly protective. You don't need a reflex where your hand is in the fire and the information travels to the brain, then comes back and tells you now to move your hand. You'd have already bent your hand. So this is a monosynaptic reflex where the afferent impulse synapses on the spinal cord, then it exits as an efferent impulse using the motor nerves. Right. This whole thing is, however, modulated by the brain. So there is a nerve that regulates activity at that cell body coming from the higher centers. Right. Then we have what we call polysynaptic reflexes, where the reflex comes, spinal cord goes up maybe to the brainstem or the cerebral cortex, brainstem mostly. Something that we'll do when we do the reticular formation, then they come back now. Those are maybe cardiac reflexes, respiratory reflexes, we'll talk about those. But a simple reflex arc should have a sensory and a motor. Right. I'm hoping you guys are following this. That's the simplest reflex arc. Right. So there's a sensory component, which is the afferent. There is the motor component. Then, of course, there are receptors where you are sensing the pain. Those are also components of the of a reflex arc. And then there are interneurons that work here, that modulate at your cell body. They're the ones that I'm saying are regulated by the higher centers. Then there are the muscles at the periphery which move your hand away from the heat or the pain or the what. Right. So I think I've described everything that is listed on that introduction to spinal cord under back. I don't know if you guys have questions on it. There is no learning without questions. There is nothing like that. Hello.
For me, no. I just need to reread. It's a hard.
Which part did you find hard? So that maybe I can try and simplify it again.
Like the last part we were talking about now. Okay, like how, like what you were explaining just now, like